Good morning, everybody. Thank you for giving me this privilege for making a presentation today for the BSI online conference. My names are Kirtika Patel, and I'm an immunologist and an allergist at Moore University School of Medicine. The topic for today's presentation is the diagnosis and management of oral allergy syndrome in a resource-limited setting like ours. Before I go on to discussing oral allergy syndrome, let's first get to the immunological mechanisms of allergy. When the allergen crosses the epithelial barrier, and it could be the eyes, the mouth, the nose, uh, the epithelial barrier, the allergen is taken up by the antigen presenting cells and presented to the T cells. Depending on the presence of cytokines, if it is IL-12, Th1 T cells would be activated, and if it is IL-4, Th2 cells will be activated. If Th1 cells are activated, then the B cells will go on to make IgM and IgG, and this is a normal reaction. But when Th2 cells are activated, then the B cells will produce IgE that will then dock onto the mast cells and cause degranulation of the mast cells that would further lead to inflammation. The mast cells, when they degranulate, they produce chemicals like histamine, which could cause itching and flushing and headache and hypotension that you normally see in an allergic patient. They also produce proteases that causes tissue damage, and they cause leukotrienes. They also produce leukotrienes that causes smooth muscle contraction, and prostaglandins, which causes vascular dilation, which is commonly seen in a severe allergic reaction causing anaphylaxis. Oral allergy syndrome is referred also to as pollen-associated food allergy syndrome. It is a localized IgE-mediated allergy, which we just saw when the Th2 cells were activated, and it usually occurs when raw fruit or vegetables, even nuts or seeds are consumed. Even spices could cause oral allergy syndrome. Oral allergy syndrome commonly affects patients who are allergic to pollen. Oral allergy syndrome or pollen food syndrome causes itchy throat after eating. In this case, this cartoon shows he's eaten an apple or a cherry or a peach, and he welcomes you to this presentation. The symptoms are limited usually to the mouth and the throat, and it occurs when raw fruit or vegetables are consumed, but it can even occur when roasted nuts are consumed. Lightly cooked vegetables can also cause this syndrome. So, for example, if a person has had stir-fried vegetables with bean sprouts or carrots, it can cause this reaction. The epidemiology is estimated that 5% of the general population in Central Europe suffers from pollen food allergy syndrome. We do not have the statistics in our country, that is Kenya, yet, but we are working on it. And this syndrome occurs in 50 to 70% of adults that suffer from hay fever. That is, if they are allergic to pollens from trees, from weeds and grasses. So these are two terms, oral allergy syndrome and pollen food allergy syndrome. And some patients experience reactions to food without them having hay fever or allergic to pollens. And the symptoms are not limited just to the oral cavity, but they can range from oral and GI symptoms to severe systemic reactions, for example, the laryngeal edema, urticaria, bronchial asthma, and food-induced anaphylaxis. So, oral allergy syndrome is a complex of symptoms induced by exposure of the oral and pharyngeal mucosa to food allergens, including symptoms of increasing severity. Oral allergy syndrome is not restricted to pollen associated food allergies, but oral allergy associated due to cross reaction with pollen antigen is termed as pollen food allergy syndrome. So, the pollen from the tree has cross reactivity with foods like apple, kiwis, and vegetables like carrots and celery. And similarly, grass pollen has its cross reactivity to various fruits and vegetables and even weed pollen. So, fresh fruit, raw vegetables, and raw nuts are common causes of pollen food syndrome. And some people can be affected by one or two foods, and others can react to a wide range of foods. The most common foods involved are apples, peaches, kiwi, hazelnuts, and almonds, even melons, but just any other fruit and vegetable or nut can be involved. The pathogenesis is that cross-reactivity occurs when specific antibody formed in response to one epitope reacts to another similar or identical epitope on another food. For example, the pollen from a tree and a melon in a fruit. These pollens and foods are not at all related botanically, but they share highly conserved homologous proteins called pan-allergens, which are widely distributed in the plants and animal kingdom. IgE directed against common cross-reactive structures shared by pollen and plant-derived foods. These cross-reactive pan-allergens, as we said, are widely distributed, and they consist of pathogenesis-related proteins that are the PRs, or the lipid transfer proteins, that is the LTPs, and profilins, and the CCDs. Some people react to nuts and seeds, which are in the LTPs, and they are not inactivated by heat. But the other proteins are inactivated by heat, therefore they are heat labile. So BET-V1 is a component in the pollen of birch tree, and it has 63% homology to MALD1, which is a component in apple. So hence, people who are allergic to birch tree pollen would probably react to MALD1 in an apple when they consume an apple. There is a lot of cross-reactivity between mugwort pollen and some spices like pepper, mustard, even peach, and herbs like chamomile. There is a risk of clinical reactivity among related foods and vegetables. For example, peach has 55 people who are allergic to peach are 55% of them react to even apple or almonds. People who react to cantaloupe has 92% chances of reacting to avocado and banana and kiwi and watermelon and peach. There's also latex fruit syndrome, where approximately 30 to 50% of individuals who are allergic to natural rubber latex also shows hypersensitivity to other fruits and vegetables like avocado, banana, kiwi, figs, chestnuts, and vice versa. People who are allergic to these fruits and vegetables also have an 11% risk of reacting to latex. So we come to the case history where this is a female lawyer from a city, and she visited her rural home where there was a lot of grass, and they were cutting grass when she visited the home, and they offered her fruit salad, which consists of melon and apple. And after consuming it, she had a very uncomfortable feeling in her mouth. Her lips had swollen, and she had itchy symptoms in the tongue and the lips. The feeling was so uncomfortable that it was enough for her to stop eating all fruits. She was very anxious, and on questioning, she had not had any allergic test. She was not aware, but she did say that during when people were cutting grass near her area, she did suffer from hay fever type symptoms, and she had an antihistamine, and it got better. So sometimes you know what you are eating. So when you eat a fish and you suffer some symptoms like tingling and itching, you know it could have been the fish that you have eaten. Or the vegetables that you have eaten, or the nuts you have eaten, because the symptoms that are caused in oral allergy syndromes are immediate. In 5 to 15 minutes, you would suffer from these symptoms, and it does get better in an hour. It is self-limiting, and it gets better in 15 in up to an hour's time. However, sometimes the symptoms caused by the offending food is not obvious. For example, if you went to an Indian restaurant and had some food, you wouldn't know whether you reacted to the cashew paste that was in one of their curries, or a sesame seeds in Asian Oriental food. So sometimes it's not obvious. But if you ever went to a Michelin starred restaurant, they use so many things, and you would have no idea what you were reacting to. The diagnosis of oral allergy syndrome is based on history taking, and that is the core component. Skin prick tests are also done. However, the commercial available skin prick tests might be negative. You will not get a good reaction because these antigens are heat labile, and when they make these commercial antigens for skin prick test, the antigen is destroyed while processing. But a fruit prick test, which is done with a fruit and then the test pricked on the skin, would give you a reaction. IgE and component testing in the blood is also done, but these are not available in our settings. But the gold standard is the oral foods challenge, where you take the offending food and eat it in supervised settings. But for oral allergy syndrome, it doesn't need to be in a supervised setting, because you would know when you get the tickling or the burning sensation in your mouth. Therefore, for setting up a good standardized history-taking tool, IACI, which is European Academy of Allergy and Clinical Immunology, set up a group of experts, and they came up with a good adult history-taking, which is important for OAS and diagnosis. And the history-taking tool is a structured questionnaire on diet and clinical history of symptoms, of atopic history, of the food and symptoms that are eaten and avoided, and various aspects of diet and nutrition. And this information then links up to interpretation of the symptoms that are triggered by the food, and linking these foods that are eaten to specific allergens and cross-reactivity, especially for aeroallergens. And then they have some algorithms or flow downs to test and diagnostic roadmap with allergy and nutritional care plan. This has been published in Clinical and Transplantation Allergy by Scalpala et al. And they have two diet history taking tools, one the pediatric version and an adult version. For our case, we use the adult version, and I'll quickly skim through what the questionnaire for the adult version looks like. So it has the symptom and atopic history uh, questions, and then foods eaten and avoided. In our case, it was the fruit like apple and melon she had eaten. And then this is linked with the symptoms. In our case, it was oropharyngeal, it was OAS, and tingling and burning sensation. And it was immediate within 2 hours of eating. It wasn't severe, but it was enough to put her off fruits. Mm, then the history taking food also links eaten to special allergens, what you usually consume in the breakfast, for snacks, for lunch, for dinner. And then it links to whether there are any hidden foods that you are eating that you might not be aware that contains the offending food. This case, we linked it with food and allergen that was the grass, and grass has a homology with melon, which she had consumed, and therefore she suffered this syndrome. And the flow down went to that she reported hay fever and reaction to various food, and it was raw when she had eaten, and the diagnosis was made of food associated oral antigen syndrome. So, oral allergy syndrome, as soon as you consume the fruit, you would suffer the reaction. It is usually self limited. However, in 1% of the cases, they would go. They would have a lot of edema and pharyngeal edema and anaphylaxis and needs hospitalization. This usually occurs when the patient has nut or soya allergen. The treatment of OAS, the most important one is that the patient should be aware of what they are allergic to. Awareness causes avoidance. So if you are allergic to melon, it is easy just to simply avoid having those foods. But in case of oral allergy syndrome, patients do get away with eating baked or cooked offending food because the antigen is heat labile. So, for example, if you're allergic to melon, if you have a melon pie which is cooked, it is okay. Peeling usually helps as well because most of the antigen is constricted in the peel. But however, some people while peeling would get a reaction. So be careful. You could probably wear gloves if you're not allergic to latex and peel the fruit. Canned fruit and vegetables do not cause those symptoms in most of the patients. However, if it nuts, roasted nuts and soya, you cannot get away with cooking it. So when you have an allergic reaction, what do? You keep calm and stop eating that offending food. So you know you are flaring up, you know you have the itching sensation. So stop it and not get tempted by saying, "Oh, I think I can get away with having one." As soon as you have the symptoms, um, wash your mouth and probably try to get a hot drink, not a very hot drink that will scald your mouth, but a warm drink that will try to get the antigen, since it is heat labile. If the symptoms persist for another half an hour, you would probably take an antihistamine. But by the time the antihistamine works, your symptoms would go away. Uh, in severe cases, when you have laryngeal edema and you would administer an EpiPen or rush the patient to the hospital where they would be treated. A lot of work has been done on immunotherapy where you get shots of the pollen that you are allergic to, and that stimulates the T regulatory cells to make blocking antibodies, and therefore research shows that around 84% of birch pollen sensitive patients had disappearance of their oral symptoms to the offending fruit. Gold standard is the oral food challenge and take responsibility of the food that you're allergic to. Class 2, to summarize, class 2 foods are the ones that are responsible for OAS. It has respiratory exposure, happens after school age, mild pruritus, tingling, angioedema, and lips of the lips, palate, tongue, or oropharynx, um, occasional sensation of tightness in the throat, caused due to raw fruit, vegetable, nuts, seeds, and it is usually heat labile. Skin prick test has to be done by prick plus prick method. Oral challenge is a gold standard. Elimination diet or heating the offending food, and immunotherapy works as well. So, in conclusion, for oral allergy syndrome, a detailed history can make the diagnosis, and then it helps for onward referral, or if there were any other test that is required. Thank you very much for your time. I'm ready to, I would be very happy to take questions, and this is my email address. Thank you so much.